Hello, my name is Randy Kojima, and I'd like to thank you today for logging into our webinar on Corneal GP Lenses. We're going to address today spherical RGPs as well as torics, Bi-Torics, back torics. And this webinar has been sponsored by Precision Technology Services in Vancouver, BC, and also by Bausch & Lomb and the Boston Lens Group. So first question we might ask is, what role do GPs play in our practice today when soft torics are doing such a great job for our low astigmats? Let's just go through a few slides and remind ourselves of some of the benefits of GPs and where they may fit in to today's clinical practice. Now, one thing that is valuable to consider is an RGP exchanges 10 to 20% of its fluid with each blink. That compares to a soft lens which exchanges only 1 to 2% of its fluid with each blink. So the oxygenation that's happening through the tear exchange with an RGP is going to be far higher than that of a soft lens. Another thing to consider is a silicone hydrogel lens will have approximately 2 microns of fluid between lens and cornea, so far less than what is the natural normal fluid layer that would exist on a cornea without a contact lens on eye. Then by comparison, the GP lens has approximately 8 to 20 microns of fluid beneath the lens or between the lens and cornea, so it's far closer to the normal tear layer thickness that we would see if the patient were not wearing any contact lenses at all. An interesting study by the University of California, Berkeley, Meng Lin, looked at what amount of time, what duration did it take for a complete exchanging of the fluid behind a contact lens. As an example, they found with soft lenses that it was 22 to 35 minutes before there was a complete and utter exchange of the fluid. So at what point did any debris come in, and how long did it take for that debris to wash out? Or any fresh fluid that's been brought in from superior as the patient blinks, how long did it take before it was expended out of the contact lens at some point inferior or elsewhere? And in soft lenses, it takes about 22 to 35 minutes to exchange all the fluid behind the lens. In GPs, by comparison, it's a much shorter amount of time. GPs are able to flush out fluid very quickly in 5 to 7 minutes. So there isn't this great buildup of cellular debris, bacteria, or any particles that we may not desire between the lens and cornea. And that may be part of the reason why we see the incidence of microbial keratitis so incredibly low with RGP lenses. Numerous studies have shown us that RGPs are the safest contact lenses known to man or woman in our practice today. The binding of unwanted chemicals or unwanted bacteria to the lenses is far tougher with the RGP lens because of the movement, because of the oxygenation that's created with the tear exchange is so powerful, and that's maybe why it can be up to 10 times less of an incidence of microbial keratitis that we see in some types of soft lenses. Another advantage of GP lenses is we know that the solutions used to manage our lenses for cleaning, for conditioning, for insertion are far less cost to the patient in a year, and typically the lenses last more than a year, so the total cost to the patient is lower with their GPs than it would be if they were in conventional soft lenses. And then from the practice perspective, we know numerous studies have shown us that RGP patients are very loyal to the practice. They continue to support the practice and continue to buy their lenses through our offices. So both their loyalty to their practitioner, but also the ancillary product that they buy in sunglasses, in solutions, in additional eye care sundries, they tend to spend more total dollars in the eye care practice. So they're excellent, excellent patients from a profitability perspective. And again, from the patient perspective, the RGPs are the lowest cost lenses that potentially they could be dispensed to. Now, maybe the most powerful reason why we fit RGP lenses today is to manage astigmatism and any kind of irregularity that would reduce the quality of vision. And certainly in a keratoconic patient, the GP lens is probably the lens of first choice because of that severe irregularity. But of course, we're still using RGPs for our astigmatic patients. And let's look at a few different eyes and analyze whether certain shapes of corneas are really good candidates for RGPs. And one might look at these pair of spherical right and left corneas, and we would say, is this a patient who really needs RGP lenses? We have a very symmetrical, normal-shaped pupillary zones in these topographies that would suggest that these patients should achieve a very high level of visual acuity. Do you need a rigid contact lens with its optimal optics on this eye? And the answer is probably no, that spherical lenses and glasses do really fabulously for these type of eyes without that irregularity. How about the width the rule astigmatism? Soft torics are doing such a great job with these patients. Do we need RGPs for these eyes? And I think with the rule symmetrical astigmat has a number of options. Glasses will clearly give this patient decent vision with a good spherocylinder refraction. We've got a very clearly defined flat meridian, a clearly defined steep meridian, a very symmetrical shaped pupillary zone. So both glasses, soft torics, and of course RGPs would be an option for these eyes. So we could go both ways with the symmetrical with the rule astigmat. The soft torics will work and RGPs will work very nicely. How about the against the rule astigmat? Is this a good candidate for RGPs? And I would argue that it is not. Many of my colleagues might tell you this is an excellent patient for RGPs. But because the axis of greatest bearing is at the vertical, or at 12 and 6 o'clock on the against the rule cornea, the path of least resistance of the contact lens, the fluid layer that allows the lens to freely move, is along the horizontal axis. So with each blink, the lens is pulled up slightly, then it wants to fall either nasal or temporal because there's a fluid layer allowing that lens to tilt across the steeper horizontal meridian. So I would avoid an against the rule astigmat in conventional RGP lenses. It might be a lens of second choice. Soft torics would probably be the preferred choice for the against the rule astigmatism. Now, the patients that I think we really want to look at GPs for are the patients with some asymmetry that exists within the pupil. And even though this is a low astigmatic eye, the lower quality of acuity that this patient achieves might indicate that we should be moving into a GP to improve that quality of vision. If you suspect that the lower VA is from an anterior surface that's not ideally suited to bend light, or if soft lenses are having trouble with the asymmetry, rotation is a factor, then obviously GP is a call that we might want to pursue. And then for the keratoconic patient, it's the obvious choice with the kind of irregular astigmatism, the high order aberrations these patients experience. These are the ones that we almost certainly go right into a GP, and it becomes the first lens of choice. Now the labs will tell you that at least 50% of what they do are presbyopic lenses. So although we tend not to be fitting a lot of sphere and toric single vision lenses anymore, there are many new fits that are coming out with GPs for these kind of more challenged optically patients. And most of the GP labs will tell you, as I said, that this is a significant part of their business. So if this is not an area that you've re-looked at the lenses, consider the quality of optics that you have through GPs and how much we require as a distribution of power within such a small area. If we have a presbyopic pupil of only 3 millimeters and we need to distribute 2.5 diopters of ad, then you put on a soft lens and expect with less idealized optics, how is that patient going to achieve really good quality near and distance? It's obvious why we are challenged so much, and that's where GP optics are really superior. Now, what are some of the considerations that we make when we fit these lenses? Let's go through some of the procedures for fitting them. And probably the patient type or the corneal type that we might fit more often than any other is the astigmatic eye that's maybe a little toward the higher side, 2.5 diopters of corneal sill. That's probably the patient that we're more likely to move into GPs. Now consider what keratometry gives you. Keratometry gives you 3 millimeters of the center, and whether it's a keratometer, whether it's an autorefractor with a keratometer feature, or even a corneal topographer that's giving you SIM-Ks, we're measuring only 3 millimeters of the center. We're not measuring inside of 3 millimeters, we're not measuring outside of 3 millimeters. So there is a lot of data that we're simply not capturing. And if you consider that a 9.5 diameter GP lens lands at approximately 8 millimeters, it's important to know the shape toward the periphery. And this patient we're looking at here has both central corneal astigmatism, but you also see a significant peripheral corneal sill. Now imagine how that might affect the fitting or landing of a symmetrical, non-toric, effectively a spherical GP lens. Now another way we might look at it is, what is the eccentricity of the eye? We know that 3 millimeters of the center is only telling us the central corneal sill, but what else can we learn about the eye shape? We know that each and every eye is very individual in both the rate of flattening in one particular meridian, but all of the meridians. So what exactly is eccentricity, or shape factor, or asphericity that it's also known at? Well, imagine taking the flat meridian and running a line and looking at the curvature across that one single flattest corneal meridian. Eccentricity describes the rate of corneal flattening that exists from the center of the eye to the periphery. The higher the eccentricity, the greater the rate of corneal flattening. The lower the eccentricity, the lower the rate of corneal flattening. Now, so what? What does that mean in the grand scheme of things? Well, imagine if you took 6 different patients that walked through the door, and they all had a central radius of curvature at the center of their cornea of about 43 diopters, or 785 millimeters in radius. If one patient had 0 eccentricity, then the height of that eye might be 1.829 millimeters. If the eccentricity increases up to normal, which is more like 0.6, then the sagittal depth of the eye drops from 1829 to approximately 1.730. If the eccentricity runs into more like a keratoconic rate of flattening, 1.0 eccentricity, then our sagittal depth of eye drops even greater. So it's important to remember that each individual eye will have a different rate of flattening, and that's why we need steeper peripheral curves on some patients, but not others. Another way to think about that, if eccentricity is confusing, and I have to admit I have a bit of a hard time with it at times, another way to think is in terms of sagittal depth. What if we were to create a cornea in cross-section and measure the height of the eye and treat the cornea like a mountain? Therefore, in the width the rule corneal stigmat that we're looking at here, across the flattest corneal meridian, The height of this eye is 1.4, 1407 microns. So the height this way, the mountain is 1407. Along the steep corneal meridian, the vertical meridian, the height is 1510. So there's almost 103 microns more depth running vertically across this cornea than there is horizontally. Now, to put 103 microns into perspective, a bubble is created at 90 microns. So if you've got that much fluid, that much greater fluid along the vertical meridian, our contact lens may have trouble both centering, being stable, being comfortable. It might even be creating bubbles at 12 or 6 o'clock. So what the modern system uses is the corneal topographer. Do you need a corneal topographer to fit GP lenses? Absolutely not. Does it help? Yes. And here's a good example. If we were to drop a theoretical lens on top of our 2.5 diopter corneal astigmat, we can see the lens landing at 9 o'clock. We can see the lens landing at 3 o'clock. And that's where you have your bearing, your touch. There's 0 microns of fluid. At 12 o'clock, where the fluid is thickest inside the optic zone junction, the inner pink circle, we have approximately 60 microns. Down here at 6 o'clock, we have about 116 microns. Again, a bubble is created at 90 microns. So if we were to place this lens on eye, you can imagine it's going to tilt across this vertical meridian when you've got all that fluid. So it's important to think about these eyes not in terms of the central corneal astigmatism, but more so in terms of the elevation. And if you have corneal topographer, that really helps you along. But ultimately, the best corneal topographer in the world is a lens placed on eye and evaluation of the fluorescein pattern. Where you see bearing, you know the elevation of the eye is high. Where you see lift, you know the elevation of the eye is low. So do you need a corneal topographer? Absolutely not. But what it does is it helps us to get to the right starting point more often the first time. Now, when I started in the industry, 9.5 diameter GP lenses were kind of the norm. This was our standard, and that was a method that dates back to the 80s. So 9.5 diameter lenses go back a ways. We have evolved a little since then, and a little means going larger. And 10.5 is now today's more normal industry standard. And why is that? Why have we gone from 9.5 to 10.5? And the reason is the larger you go, the more stable the fit. The more stable the fit, the less it moves. The less a contact lens moves, the more comfortable it is. And that's why a soft lens that fits very poorly is horribly uncomfortable. That's why a GP that's moving 3 millimeters with each blink is very uncomfortable. Conversely, a well-fitted soft lens is very comfortable, an 8 or a 9 out of 10 on a comfort scale. A scleral GP lens is typically an 8 or a 9 on a comfort scale, and that's because they don't move. So the more we reduce GP movement, the more comfortable lenses become. It's that simple. Now, historically, we would use an empirical fitting chart. We would look at the size of the cornea and say, we won't have a smaller cornea, we'd use 9.2. We have a larger cornea, we'd use 9.5. And then we'd go along the list and look at the corneal astigmatism. If we had 1 3/4 diopters corneal astigmatism, if we were fitting the 9.2 lens, we'd use the flat K as our base curve. If we were using a 9.5 lens, we'd go a 1/4 diopter flatter. So that was the fitting nomogram on a 9.5 diameter or 9.2 or 9.5 diameter lens. Today, with these larger diameter lenses, the typical way that precision technology would build a lens for you is to use a high aspheric back surface. We would match the eccentricity of the lens to the natural eccentricity of the eye. So in doing so, we need to fit the lens approximately 1.5 diopters steeper at the apex because that lens is going to have a very high rate of flattening, similar to the corneal rate of flattening. The major difference between these lenses is certainly that asphericity from the center of the lens, but an important thing, and maybe the most important factor, is larger. We fit smaller corneas with 10, we fit normal corneas with 10.5, we fit larger corneas with approximately 11 millimeters. Then, with the modern method, we're relying far more heavily on corneal topography. Again, you don't have to have a corneal topographer, but it really tells us this patient here has to be in a Bi-Toric, a spherical GP with 60 microns of fluid heading north, 160 microns of fluid heading south. That's going to be a lot of fluid, a lot of tilt of the lens across that vertical meridian. It's going to be a problem. So knowing how much to tighten it up is really beneficial. So what we would do then is take the horizontal meridian, try to land the lens down at 3 and 9 o'clock. What we're hoping to achieve is this lateral touch at 3 and 9 o'clock, which you can see on the graph. So with the topography derived method, you actually ignore the fluorescein pattern here and you look at the graph down below. You take this white axis line, drag it around 360 degrees, and look for the meridian of most bearing. Here's landing at 3 o'clock and landing at 9 o'clock with a healthy edge lift on both sides and a healthy apical clearance in the center. But that's only part of it. The other part is that in the vertical meridian, when we take our axis line to where the fluid appears the thickest, we want to see this nice linear channel, this fluid layer running all the way through the lens. And the hope is that we can create a good tear pump with each blink. We can exchange the fluid that we want with each blink. So what are the fitting considerations that you need to make whether you fit empirically or with a corneal topographer? And the most important thing that you need to look at with your GPs, rule number 1, is what is the apical clearance? That lens must clear the corneal tissue. If you don't clear the central cornea, the lens can't land in the mid-periphery and create a stable and comfortable alignment with the periphery of the eye. So for instance, by clearing the cornea, you can see where we're landing here at 9 o'clock and again where we're landing at 3 o'clock. We've completely cleared the corneal apex, which allows us to land in the mid-periphery. The second rule is that we're hoping that we have horizontal alignment, that we have a meridian of greatest bearing that's at 3 and 9 o'clock. Now, why 3 and 9 o'clock? If it's sitting on these, as my colleague would say, Pat Caroline, the rails at 9 o'clock and 3 o'clock, it can't laterally shift. It's opposed, its movement is opposed in the horizontal meridian, and that way you have a very laterally stable lens. So that's rule number 2. Now rule number 2 is tougher to achieve when you have an against the rule cornea. Your bearing is going to be at 12 and 6 o'clock, and that's why the with the rule cornea tends to be the more ideal RGP patient. Now, rule number 3 is that we want to achieve a meridian of lift. We want to create that good tear pump. We want a fluid layer to run from one side of the lens to the other. And ideally, we want that fluid layer to be in the vertical. And why the vertical? Because with each blink, we want that lens sucking fresh fluid from superior and flushing it out inferior, sitting on the rails at 3 and 9 o'clock and just pushing the fluid from above underneath the lens and expending it down below. Again, on an against the rule patient, going to be tough to have that vertical meridian of fluid, but on the with the rule cornea, going to be very easy. Nature's working with us and not against us. Now, rule number 4 is to look at the edge lift of the lens. And where do you focus more? Should we focus on 100% of the edge lift, 360 degrees around, or do we look specifically at the horizontal meridian. And the idea is the horizontal meridian is most important because as the patient changes their fixation, nasal and temporal, they're going to drive the lens in the opposing direction. So what you want is enough edge lift to exist at 3 and 9 o'clock. So as the patient changes their fixation, that edge lift will be high enough that as we hit the limbus and the peripheral cornea, that we're going to have enough of a ski tip. It's going to be effectively lifting off enough. Now, what if these patterns are tougher to discern, tougher to make out? And without a Ratten filter, it's very difficult to really make out the pattern, especially with certain lighting and certain slit lamps. So consider how important acquiring a slit lamp is from your lab. You can get it from us here at Precision Technology, supplied by Bausch & Lomb. Now, if you've got the optimal Ratten filter to use, then what if you're having trouble making out the pattern? Consider pulling up the upper lid and removing that from affecting the lens. What happens if the lid is out of the way? Where does the lens want to position? What if the lens is riding extremely low? What if I push the lens into a more centralized position? And if the lens I'm using isn't giving me an optimal fit and I don't have a trial lens that's anywhere close, then if your right and left eyes are at least a half diopter separated, then try switching right to left and left to right to get a better perspective on if steeper or flatter will work on either eye. Now, it's important that you have your consultant, and you've got a couple precision technology consultants that you can call upon when you've got trouble. Remember those rules. The apical clearance, figure out the meridian of greatest bearing, figure out the meridian of greatest lift, and what your edge lift is like. With those 4 rules, we can resolve most problems that you're having with your corneal GP fits. But also consider the lens position. Where's the lens in its habitual spot in between blinks, before and after the blink? What's the movement like? Is it horizontal? Is it vertical? How does the lid affect the lens? Does the lid hold it up for a period and then squeeze it out and push it down, or does the lens just want to hold on to it and keep it riding high? Then, of course, if you're having a really difficult time with the pattern, just push that lens into a centered position and assess the pattern when it's very central. That way you can get some idea of, is this lens even in the ballpark of fitting this eye? And that's especially helpful when we're dealing with the more keratoconic, more diseased eye patients. So let's fit a patient. Let's take somebody with a simple width the rule astigmatism of about 1.4 diopters. Assume that it's fit by keratometry or topography. You've got just a simple width the rule corneal stigma with about 1.5 diopters of SIL. We might put on a lens, and our rule number 1 is to create enough apical clearance that that lens clears the corneal apex. So ideally that's approximately 20 to 30 microns of fluid underneath the center of the contact lens. And then that should allow for us to land in the mid-periphery. We want our lenses to land at 3 and 9 o'clock. And with a width the rule patient, that should be easily done. Nature, again, is working in our favor. Now, in the vertical meridian, what we're hoping for is to have that nice channel, that fluid layer for that lens to freely move. And we see along this white axis line, the arrow, that we've got this nice linear fluid layer. It's no more than 40 microns heading toward 12 o'clock and around 20 microns heading toward 6 o'clock. If that fluid layer is greater than 40 microns, then that's going to create an unstable fit. So you therefore would need a toric contact lens, a toric rigid lens. And here's the same fit that we just designed topographically. We could achieve the same fit if we didn't have a topographer. We might just put on more lenses than just one. But you see a healthy apical clearance, a lens that lands at 3 and 9 o'clock. You've got this nice bearing out here in the periphery. We've got a healthy edge lift at 3 and 9 o'clock, and we've got this healthy channel running all the way through the vertical meridian. So that's what we want to achieve with all of our spherical and toric GP lenses. Now what if we took this patient and against the rule corneal astigmat? You've heard me mention numerous times that this may not be the best candidate for our GP lenses, but we have quite a high corneal astigmatism, about 2 3/4 diopters of corneal sill. So is there hope of a corneal GP working on this patient? Well, let's look at the horizontal meridian and fit a spherical lens on this eye. And if you look at the white axis line and correspond that to the graph down below, here's 12 o'clock, your edge lift. There's landing up to your apical clearance. Then you're landing at 6 o'clock and your edge lift toward the very tip. So the problem here, you can clearly see, is that our lens is going to sit on those rails at 12 and 6. It's going to be hindered from moving along the vertical meridian. The bigger problem may also be that we've got this horizontal meridian of lift, and when we take the white axis line to find the fluid layer that is thickest along a particular axis on this lens, it looks like we're above our 40 micron threshold on the one side and well above on the other. So you can imagine how poorly this lens is going to fit. We've achieved apical clearance. The lens has cleared the corneal apex. It's landing in the mid-periphery, which is good, but we've got that fluid layer running all the way through 3 and 9 o'clock, which causes the lens to decenter. With the blink, it's going to be pushed nasal or temporal. It's going to move a lot. It's not going to be exceptionally comfortable for this patient. So can we do something about this 2 3/4 diopters of corneal sill? And the answer is yes. Because the cornea is so toric, we can create 2 meridians of curvature on this eye. Across the flattest corneal meridian, we might try to land the lens down and create that touch on lateral sides that we want. Along the vertical meridian, we'll try to have a nice channel running through that vertical meridian, and you can see that here. Instead of having all kinds of fluid running across the horizontal, we have a nice little fluid layer running across the vertical. So by creating a Bi-Toric lens for this eye, we can actually create the same pattern that we want on a moderate with the rule corneal astigmat. The lens clears the corneal apex, the lens lands at 3 and 9 o'clock, and the lens has a very, very thin layer of fluid, about 20 microns, running all the way through the vertical meridian. So this is what we want to try to achieve with all of our GP fits. And if we can, we give ourselves the best opportunity to have a comfortable lens for the patient and being therefore successful. Now let's look at apical clearance for a second. Let's focus in on the upper left-hand image. How would you assess the apical clearance of this lens? Would you call it ideal? Would you call it excessive? Would you call it inadequate? And one of the first things that we teach our students is to look for the pupil. If the pupil is tougher to make out, you may have too much apical clearance. Of course, the bubbles, the dead giveaway that we have excessive apical clearance with a little bit of dimple veiling. So certainly this lens has excessive apical clearance. The middle image, what would you call the apical clearance of that lens? Would you say that's acceptable? It's excessive, it's inadequate. And the first thing we might look at is it seems to clear the corneal apex. There's definitely fluid there. But can we make out the pupil? And the answer is yes. So we call that more ideal as far as apical corneal clearance. Now if we look at the bottom right-hand image, clearly this lens has broken rule number 1. It's hit the corneal apex, and because it's hit the corneal apex, it's trying to find an opposing point of bearing. So what does it do? It pivots off, generally laterally, nasal or temporal, and it finds an opposing point of bearing to hit. So that's why you have this very arcuate area of bearing of the lens. The lens is riding high, so that also tells us that it's probably flat. And so in this lower right-hand image, we'd want to go steeper. Now what about bearing? Let's look at rule number 2. Where do our lenses come down and find their landing? If we look at the upper left-hand image, it looks like we've got this arcuate landing at 3 o'clock. Same thing with 9 o'clock. So this is good, but the lens is riding a little on the low side. It's got lots of apical clearance, so we can afford to go a little flatter. The central image, we've got that nice landing at 3 and 9 o'clock, exactly what we're looking for, and that fluid layer running all the way through the middle. With our very flat-fitting lens, with it hitting the corneal apex, it's a waste of time to look at what's happening out here in the mid-periphery, because we don't have a lens that's cleared the corneal apex, so it's never going to land appropriately in the mid-periphery. Now, where's the meridian of greatest lift in all these fits? And we've changed to some different lenses now, different eyes. Would you call this a with the upper left-hand image a with the rule cornea or against the rule cornea? And I think clearly with the bearing at 12 and 6 o'clock, this must be an against the rule patient. And you notice because we don't have that landing at 3 and 9 o'clock, the lens can decenter more. This patient here looks like we've got the landing closer to the horizontal meridian, but we may be so flat across this meridian that the lens is tilting and it's bending in, touching at 2 o'clock, 1:30, somewhere in that neighborhood, and lifting off a lot here. So this is probably a very astigmatic eye, or much more astigmatic eye than a sphere would be. The other question would be, do we have enough apical clearance? Have we fit the apex steep enough to land tight enough in the mid-periphery? Our last fit, it looks like we've got great landing at 9 o'clock and at 3 o'clock, but we've got a lot of edge lift, and that's causing the lens to ride a little bit on the high side. So apical clearance-wise may be acceptable. We can just make out the pupil. We've got the landing we want at 3 and 9 o'clock, but I think we can steepen up the edge quite significantly. Now, what about position? What can we use as rules to determine which direction to go? Should we go steeper or flatter? And when you've got a high riding lens, like you can see in the upper right-hand corner, generally that's a flat fit, so go steeper with your base curve. If it's a Bi-Toric, go steeper in both meridians, or if the vertical meridian is excessively lifting off, then go much steeper along the vertical. But generally, go steeper in base curve if it's a sphere, go steeper in both meridians if it's a toric. The middle image, when you have lateral decentration, it's usually one of two things. It's either an against the rule cornea, which this one is not. This one, the problem is we've hit the corneal apex. So if you have lateral decentration, go steeper, similar to if the lens is riding high. And then lastly, if the lens is riding low, that's generally a fit that's too steep, so we would fit flatter. So the lens is riding high, that's probably too flat a fit, we'll go steeper. Lens riding low, that's probably too steep a fit, we should be going flatter in base curve. Now, as far as edge lift goes, this is a very confusing area for a lot of folks, and I have to admit I'm one of them. One of my mentors encouraged me to look at the width of the edge lift. They tell you that you want 60 to 90 microns of edge lift, but that's pretty difficult to make out. So look at the width, and 0.5 millimeters width of edge lift is what you're looking for. So in the upper left-hand image, what would you call the width of this edge lift? And I have no idea, but I'll guess 0.1. It certainly doesn't look like a ½ millimeter. So this is clearly too tight. We need increased edge lift in this contact lens. The middle image looks like we've got much closer to that ideal ½ millimeter width of edge lift. Then lastly, the lower right-hand image, it appears like we've got at least 1 millimeter of edge lift, maybe more than 1 millimeter. So if you're not sure, let the patient decide. If you're having trouble removing the contact lens, you may have a inadequate edge lift like we see in the upper left-hand side. If there isn't enough of that ski tip at the edge, then what is the patient going to grab onto with their lids if they're using the blink or scissor technique, for instance? Now, what about if the lens is popping out much too easy? Then possibly it's more like the lower right-hand image where we've got excessive edge lift, and we therefore should be reducing the edge lift. What about 3 and 9 o'clock staining? If you've got mechanical disruption of cells, then it's more likely the upper left image. We've got inadequate edge lift. But if 3 and 9 o'clock is producing staining that's more from drying out, then it could be more likely from the lower right-hand image where we've got all that fluid, all that edge lift at 3 and 9 o'clock, and that might be creating a suction force here and here that's drawing in the fluid just peripheral of the lens. So 3 and 9 o'clock staining can happen from too little edge lift mechanically, or it can happen from too much edge lift when it's more hydraulic related. So this is what we're looking for as an optimal GP fit. What would you call that apical clearance? And there's so many rules of thought. There's so many philosophies on what is appropriate apical clearance, but any definite fluid molecules, fluorescein molecules behind the lens, you can pretty confidently say the lens is clearing the corneal apex. If it's excessive enough that it's hard to make out the pupil, then that might be where we'd want to flatten the base curve. You can see the landing of the lens in the mid-periphery at 9 o'clock and again at 3 o'clock, maybe going in a U-shaped pattern with the upper lid pressure pushing the lens against the superior cornea. But the important thing is we've got this touch at 3 and 9 o'clock. Now, what if the width of this bearing is 2 or 3 millimeters? Is that a problem? And you don't have to worry about the width of this black, or what we'd call the bearing or landing. If you have a healthy edge lift out here, that tells you that the lens is coming, kissing down slowly, coming back up, creating its apical clearance. You actually want to see a very wide area of peripheral alignment. Of course, if the lens is staining out there, that tells you that you don't have a nice soft landing, but generally, if you've got a wide area of landing, it's kind of like a distribution of pressure over a broad surface area. So the patient will likely feel it less if that surface area bearing is much wider rather than much more narrow. So tonight we've addressed corneal GPs, and I'd like to thank everybody for joining us. The next webinar will focus more on myopia control and myopia control techniques. And what we're hoping to cover is all the methods in contact lenses that might be able to address in myopia control in young kids. So that's GP lenses with aspheric optics, that's soft multifocal lens with obviously aspheric optics, and orthokeratology. So we'll cover quite a broad range, and then we'll continue on and go through 6 webinars with different topics and cover more advanced types of fits with each one of the monthly webinars. So I'm excited about this next one. It'll take place on November 25th, Monday at 6 p.m. Pacific time. That's Vancouver time, and it will review a lot of the current studies that we've seen come out in the last 10 years. There's been just a massive amount of study into why kids around the world are progressing in myopia at the rates that they are. So we've got some tools, and that's what we're going to address. Now, before we close up, we'll just remind you that Precision Technology is a GP lab. We do custom and specialty single vision lenses, multifocal lenses. We have numerous scleral soft lenses for both disease and ocular surface dry eye type patients. We've got custom soft lenses, the TheraTears products for dry eye. You can acquire most of your Boston solutions as well as Ratten filters and DMVs, as well as we are the North American distributor of the Medmont Topographer and their field analyzer and digital imaging software. So I'd like to thank everybody for joining us tonight. I apologize for some of the early technical difficulties, but I hope that you found the webinar beneficial for understanding how we might approach some of our single vision patients in both the conventional GPs and the Bi-Toric lenses.